So good evening to everybody. My name is Dov Engelstein, and I'm the president of the Israeli Urological Association, and that's why I'm starting. And we are very happy to welcome Professor Witjes and Dr. Katz, which is an honored member of our committee, will present the professor, and we are very happy to have you here. At the same time, just one comment. This is the Jewish New Year, and Shana Tova to everybody. Happy New Year, and Chatima Tova. Ran, the floor is yours.
Thank you. Well, good evening, everyone. We're very proud to have Professor Witjes with us. He's a professor of oncological urology at the Radboud Medical Center in the Netherlands. His research interests are translational and clinical research in bladder, prostate, and testicular cancer. He has many training and teaching activities. He's a member of several international societies, and he chairs, amongst others, the Dutch Guidelines Committee on Bladder Cancer and the EAU Guidelines Committee on Metastatic and Muscle-Invasive Bladder Cancer. He's a reviewer of many and editor of several urological and oncological journals. He is involved and leads many studies and projects which have resulted in many lectures and over 580 peer-reviewed publications, reviews, and book chapters. Again, we're very happy to have you here. The topic of the lecture will be follow-up of non-muscle-invasive bladder cancer, including the place of urinary biomarkers. Professor Witjes, please.
Okay. Dr. Katz, Dr. Engelstein, thank you very much for this very kind introduction. And although it's not New Year in the Netherlands, I wish you all a happy New Year. And of course, amongst a lot of things, we hope that we will be freed from the corona problem. I will have one slide on that at the end of my lecture. So I was asked to talk about follow-up of non-muscle-invasive bladder cancer, including the position or the place of urinary markers. And like you heard, I'm a urologist, oncological urologist, working in Nijmegen in the Netherlands. So I do have some conflicts of interest, and especially as you can see on the left lower side, I have done some studies with several urinary markers. By the way, I did the same in the first decennium of this year with a lot of markers, the BAR test, the NMP test, which never made it to clinical practice, but we have had a lot of experience with markers in the past and also currently. So let's just talk a little bit about non-muscle-invasive bladder cancer and treatment. Of course, you know that treatment is actually based on risk groups. And if you want to look at those risk groups or want to know anything about non-muscle-invasive bladder cancer, I would advise you to go to the guideline or the manuscript that has been written by Marco Babjuk last year in European Urology, summarizing the guideline. So the risk groups, I think everybody knows that, and the strength rating is strong because the risk groups have a very different way of recurrence and progression. Low risk is predominantly the small solitary TA low-grade tumors, of course no CIS. On the other hand, you have the high-grade risk group, that's high-grade T1 and CIS, and then a very seldom patient with multiple and recurrent and large low-grade TA tumors. And the intermediate group, which actually is the largest group, because everybody with a recurrent TA, for example, is intermediate. The intermediate risk group is the rest. Of course, there is different treatments in all these patients, like it is in the highest risk group. This is a group that we have defined within the EAO. The AOA doesn't have this risk group. And, you know, if you look at these definitions, I think that makes sense. The very high risk group is T1G3 with CIS, multiple, large, recurrent T1G3, CS in the prostatic urethra, very nasty, variant histology, like squamous cell or other variant histologies, and of course also lymphovascular invasion. So this translates into treatment, and to summarize that again shortly, of course for the low risk groups, we do a TOR, we have to do a good TOR, and then a single post-op installation is effective, safe, and actually enough. There are some alternatives like active surveillance, fulguration, or 24-hour post-op TOR bladder irrigation. Then the intermediate risk group is actually treated with a course of installations or chemotherapy or BCG. The high-risk group also was very strong recommendation to use maintenance BCG. That's, if you do that very well, 3 years of maintenance BCG. Know some issues, because we have, of course, a problem with BCG in the Netherlands. Maybe you also have that in Israel. No issues about the dose, reduced dose, the schedule, the reduced schedule, and the strain that you're using. And in the highest risk patients, actually you should discuss with your patients to do a cystectomy, because that's really a dangerous disease. There are alternatives, but the experience still is limited. And thank God, the last few years, there are some very interesting new therapeutic developments like vaccines, like PD-1 and PD-L1 antagonists. And I would advise you to read one of those new manuscripts on these new therapies, like a very recent review done by the group of Gary Steinberg. Follow-up is also based on risk groups. And that's, as you can see, already a little bit less well defined. Low risk, you do a follow-up schedule at 3 months and then yearly, and you stop after 5 years. No upper urinary tract imaging. The high risk group, you do that 3 monthly, 6 monthly, yearly, and actually you have to do that for a very, very long time. And the intermediate risk group is something which you actually can make up yourself, and it's in between. The AUA, for example, has a similar recommendation. But we have to realize that the recommendations are actually mainly based on retrospective data. So the level of evidence of these recommendations is actually very low. You can already see the difference. For example, in the UK guideline, you can see what I underlined. If the cystoscopy at 12 months is negative, the UK NICE guideline recommends to discharge the patients back to primary care. So apparently there is not that much proof for what we are doing in our daily practice with regard to follow-up of non-muscle invasive bladder cancer patients. Some general remarks about follow-up of these patients. I think we all realize and agree that the first cystoscopy at 3 months is important. If that's negative, patients have a much better prognosis than if they have a recurrence at 3 months. In low-risk patients, recurrence is the problem. It's usually in the same stage and grade, so early detection is not essential. It's not life-saving. On the other hand, in high-risk patients, you see a lot of progression, so the primary goal is to recognize the patient early enough to prevent progression to muscle-invasive bladder cancer, because if that happens, that really can be life-threatening. So what are the data on which we base these assumptions? On the left side, you see the old EORTC scoring list. And then you see in the upper left corner that you get some points for the size of the tumor or the grade or the presence of CIS. And if you then add all those points, you see that in the left side. On the lower side, for example, if you have 1 to 4 points, you will have 46% chance of recurrence at 5 years. And if you look at progression, for example, if you have 2 to 6 points, you will have a 6.6% risk of progression. Although I am co-author of this manuscript, I have to be honest that not a lot of people use this anymore. Basically because all these studies were very old, and these data are based on studies without BCG, without maintenance BCG, without a single post-op installation, and without the re-TOR. So it's basically historical data. On the right side, you see that first the Spanish group by Fernandez Gomez, and after that the EORTC themselves made an update. And there you can see that the percentage of progression in high risk, for example, is much more realistic, around 20% in 5 years. But still, that means that of the innocent non-muscle invasive bladder cancer patients, around 20% will have progression to muscle invasive disease, which is a totally different disease within around 5 years, in spite of, in this case, adequate BCG treatment. But also small low-grade tumors can do very bad. This is a very large overview from 2014. TA-G1, and of course there's always some discussion about pathology, but still these patients were thought to be at a very low risk. You see something we recognize, a 5-year recurrence rate of around 40–40%, but what we don't recognize, or maybe don't even realize, that in these patients the 5-year progression rate is around 5%, and there is even some cancer-specific mortality in case of an initial T1, G3 tumor. And of course that depends on age, previous recurrence rates, but still, it is not an innocent disease. And if we're going to do follow-up, how long should we do that? These are two very nice studies. They both had the same material and methods actually. So they looked at patients that were 5 years tumor-free on a follow-up, and they took the 5-year time point as T0. And after that time point T0, where you might think, okay, let's discharge the patient. After the time point T0, you see that in the first study, 15, and in the second study, 11% of those patients still had a late recurrence. So actually, how long should we follow up these patients? Is 1 year enough? Is 5 years enough? Should we do that lifelong? So that remains a very difficult decision. And how do we do the follow-up? Actually, the way that we do that is with cystoscopy and cytology. And you see that cystoscopy is a grade A recommendation, but it has some limitations, and I will show that in a few slides. What about cystoscopy? Well, if you look at this slide, you see that it's an older study from the ORTC. These were patients that were treated in the OR with a resection, under anesthesia, with a rigid cystoscope. And still you see that the 3 months recurrence rate was at the most 45%. And I'm quite sure that most of those so-called recurrences were missed lesions during the initial transurethral resection, simply because we didn't see them very well. I'm sure with, for example, blue light or NBI, we do better in 2020, but still we don't do a perfect job. And we also have seen that in the studies with blue light, both of the diagnosis studies, I've been involved in many of those. And if you look at something that is really difficult to see, carcinoma in situ, you see that we miss 62% of the lesions. Well, okay, that's maybe not a large problem, but we also miss 30% of patients that have CIS. And I really think CIS is something you shouldn't miss because it has really consequences for your therapy. So in all, that means that our cystoscopy is by far not ideal or perfect. And the other thing is that we do a lot. This is a group, it's a Veteran Administration study from last year from the United States, where they looked at newly diagnosed low-risk patients. They defined an optimal follow-up schedule, as you can see, and they looked at how many cystoscopies were done. And the conclusion was that there's overuse of cystoscopy in 75% of patients. Over 800 of those 1,100 patients had too many cystoscopies. Even assuming that all those low-risk tumors were large and multifocal, still 45% of those patients had too many cystoscopies. So I think the correct conclusion is that overuse is very common, and that raises, of course, concerns about costs and quality. And then the other thing that we use in follow-up, urinary cytology. Well, I think we all agree and know that the specificity of cytology is very high. You know, if cytology says there is something, probably there is something, but we also all know that the sensitivity of cytology is not very good. In this review, you see in the middle here below that it was around 44%, and I think in many practices it's probably even lower because these are published results. I think one of the reasons that we can use cytology, that's also actually my way of using cytology, actually just most helpful in the follow-up to find high-grade tumors. In primary diagnosis, it doesn't really give you a lot of help. And that's also translated in the European guideline. If you have a abnormal cytology, if that's positive and you don't see anything, you have to look further or use blue light, do endoscopy, or take biopsies. So positive cytology with a high specificity certainly is a reason to look further than only a negative cystoscopy. So what do we do currently with regard to follow-up? My conclusion is we do too much, we do things of low quality, and we have a very low level of evidence of what we're actually doing in follow-up. So maybe urinary markers are the solution. I will first talk a little bit about some of the older ones. Again, I've done studies with all those markers in the 90s and the first decennium of this century. And I guess most of them have disappeared. What's still used a little bit is the Eurovision test. It's an haploidy test for chromosomes. It's a FISH technique, fluorescent in situ hybridization. which is relatively difficult. It is relatively time consuming and expensive. And as you can see, sensitivity, if you compare it to cytology, is better, but you lose some specificity. So it's not an optimal test. And then I've done some work with the NMP22 test. You see, it's a nuclear matrix protein test, which is released after cell death. And there's a much higher concentration in malignant cells. So in bladder cancer, this should be and is elevated. The big advantage is it's a dipstick, so you have the results in around 30 minutes. But you see the sensitivity is not that good, 68%, a bit better than cytology. And again, you definitely lose a lot of specificity. So again, for sure, not an ideal test. And this is a nice review by Daira Tickly. She's now working in Hamburg currently, about all those tests that were, let's say, available in the first decennium of this century. They have a higher but still insufficient sensitivity compared to cytology. Specificity goes down, and they have not really decreased the need for cystoscopy. So their conclusion was that urinary cytology, or in this case, the older markers, cannot safely replace cystoscopy. And that has translated into the EAU guideline. As you can see in the lower line, the clinical consequence is that markers are not recommended in the EAU guideline. Some other issues that you have to take into consideration is that some benign conditions, infections, BCG treatment will influence your urinary markers, so you can't use most of those markers in case of an infection. You have to realize, if you look at studies, how markers have been tested, is that in a screening situation, was that for primary detection, was that for follow-up, and also in which patients it has been used. Is that in a high-risk category of patients, like still some companies do, for example, in Germany, or is that in the general population? So there are a lot of issues that are important when you look at studies that are using biomarkers. So also with regard to biomarkers, I think there's definitely room for improvement. And one of the things that I think is very important, and the Nucleix company, for example, has looked into that and has recognized that, is that markers might be of use in follow-up. As a urologist, I probably would never, in the initial setup, in the initial diagnosis, use a marker instead of a cystoscopy. If a patient would come to me with hematuria, and I would think that he would have a bladder tumor, I would actually always do a cystoscopy and never rely on a marker alone. So the follow-up setting, I think, is a very wise decision to look in that group of patients. Markers and follow-up, what have we seen the last few years? Well, recently there have been several promising studies on markers in follow-up of non-muscle-invasive bladder cancer. And the goal of those studies, the goal of those markers is to reduce the follow-up cystoscopy frequency. And of course, that is an advantage for the patient since it's a non-invasive test and it doesn't have side effects. So there is a clear goal that we can try to get with markers. And another thing that is important since a few years is epigenetics. Epigenetics are factors that switch off or switch on genes, affect how cells are read the genes and without altering the underlying DNA sequence. And the potential consequences are, for example, cancer development, progression, or even impact on therapy. And there are three categories of epigenetics that are currently used and have a lot of attention. That is aberrant DNA methylation, hypermethylation or hypomethylation, histone modification, and non-coding RNAs. And why is that important for bladder cancer? Well, first, the techniques are improving year by year. The current high throughput techniques make research much easier, the results better, quicker, and cheaper. And consequently, the body of literature is growing exponentially. And epigenetic changes are frequent in cancer, also in urological cancers, also in bladder cancer, and even also in non-muscle-invasive bladder cancer. And you can use both tissue and urine to get a result. So that certainly looks to be useful in diagnosis, prognosis, and maybe even as a potential target for therapy, since some of these changes are reversible. Well, Nucleix has worked on that, and they have come up with a new urine-based hypermethylation test. It's the bladder EpiCheck, and it's a test for surveillance of non-muscle-invasive bladder cancer. We've done a study. I will show you the results in a few moments. It's a real-time PCR technique. You only need a little bit of urine, at least 10 ml, so that should not be a problem for your patients. Epigenetics uses 15 proprietary DNA methylation markers to find bladder cancer, and they're not the 15 best ones, but the most complementary ones. So that's a smart decision. And the AP score gives you a number between 0 and 100. It's calculated by a software algorithm, and it presents the overall methylation level of the sample. And it is considered positive, so not good, if the score is above 60. Here you see the flow. So you just have to have a little bit of urine, 10 ml. You can ship that, or if it's cooled, you have 5 days time to ship that. And in room temperature, you have around 24 hours to ship that or to bring it to the lab. In the lab, you have some processing, and then you will get a report, a printed report. And as you can see, for example, in this case on the right side, this patient has a positive score of 90. So in this case, there probably is a tumor. The first study was done in Israel, an independent cohort of 222 patients with a high sensitivity of 90% and a high specificity of 83%. The authors found that the sensitivity increases with stage and grade, which is of course nice, and they found a negative predictive value of 97% in a cohort that had an 18% prevalence of positive patients. So that means that if the test is negative, the chance that you will have a tumor is low, around 3%. And the EPI score also increases with stage. The reason to extend this to a multi-center study, it has been done in 5 centers in Europe and in Israel. It's around 3 to 5 years ago. And the gold standard was histoscopy, biopsies, and cytology. And again, the wise decision was to use patients in follow-up after non-muscle-invasive bladder cancer. They would have to be within 1 year after TUR, and treatment or urinary tract infection was not an exclusion criterion for the study. In most of the studies I've done, it was an exclusion criterion. And you see here of the 1,440 patients, we evaluated 353. That's the performance analysis. We had 46 positive patients according to the gold standard. And you see that the overall negative predictive value was 95.1%. And the overall and the negative predictive value for non-low-grade TA recurrences, so anything worse than low-grade TA, was even 99.3%. And fortunately, and again, there was no influence of urinary tract infection or of instillation therapy. And we also found that the EPI score increased with stage and grade. This study has, of course, as the study has a few small limitations, we didn't have any follow-up, so we couldn't check the false positives, whether they are going to get a tumor, yes or no. And in this study, we had only 46 recurrences. And here you see, for example, a subgroup of treatment ongoing, yes or no, and you see there is no difference in the outcome of the test. Because we didn't have that many patients, there was an extension study which was published at, or presented at the EU last year. And we more than doubled the number of patients. The material methods were similar, and we could confirm all previous results. And as you can see here, you see that the negative predictive value in non-low grade was 99.3% in the original study and 98.8% in the extension analysis, so around 99%. This is a very recent publication by Mancini in a journal which I would normally probably never have read, but I just found that. And you see there are now, in the meantime, 6-7 studies done with the Epigenetics. And you see in total it's a fair number of patients. And if you go to the right, you see that the negative predictive value of all these studies is high. There's one outlier, but the rest is almost all 90 or to 95%. And if you go to, I think, the most interesting group, the non-low grade recurrences, you see that the negative predictive value is very high, 99.3% in my study, extension cohort 98.8, another study 99.3, and one study even 100%. So meaning that if you use this test, if the test is negative, of course the patient might have a small recurrence, the chance is low, but the chance that he has a high grade recurrence is very, very low. And that's, of course, very nice for you and for the patient. This is not the only test. I already mentioned that there are more publications and more tests. Just shortly, Radboud Conetti, a good friend of mine from the United States, used the CX bladder test. It's a microRNA, and they had 4 studies, and also they found in their test a negative predictive value that was very high, 97%. And quite recently, Martin Ruppert published on the ADX bladder cancer test. It's a novel biomarker. And also in this case, this test had a negative predictive value of 93%. And for the non-PTA low-grade recurrences, it was even 99%, just like for the Epigenetics test. And the expert bladder cancer monitor, which we also studied and published last year, it's again 5 microRNAs. One of the advantages is that the cartridge and the machinery is present in a lot of hospitals in the world, and it has a very relatively short turnaround time. And also in this test, you see that there is a very high negative predictive value, both overall and also for non-low-grade recurrences. So looking at the urinary marker test, my conclusion would be that the older ones, the FISH test, the NMIBC test, are not widely used because of all kinds of issues, costs, practical aspects, insufficient sensitivity, insufficient specificity. I think in follow-up, a test with a very high negative predictive value, certainly for high-risk tumors, may result in less cystoscopies. And then alternating cystoscopy and cytology with a new test like, for example, the Epigenetics test, could reduce the current diagnostic burden, both for you as urologist and also for the patient. How did I implement that in my clinical practice? So I think the number of follow-up cystoscopies is very high, so it's a lot of workload. I see in my practice around 10% of patients having a recurrence, and I have to admit, if that's a low grade and a low stage recurrence, which I then base on the history and what I see, I even leave those recurrences in place and I do follow up. That means that usually, fortunately, most of the cystos are without consequence, meaning that I don't go to the operating room for TUR right away. So the conclusion is I would really love to reduce this workload, and patients also. And I will talk about that a little later. Since the Epigenetics test is stable and reliable, I currently alternate the Epigenetics test with cystoscopy. Because, you know, if the test is positive, I still can do a cystoscopy. That's how I inform my patients. And to prevent unnecessary traveling, Netherlands is a small country, but still, this is for patient comfort and cost. The urine sample is sent from home, and I have a telephone consultation with the patient when I get the results. This is how this looks. So if the cystoscopy is positive or negative, if it's positive, the bladder Epigenetics test, of course, I will plan cystoscopy. And if it is negative, I will phone the patient and make an appointment for a new cystoscopy, alternating again with the bladder Epigenetics test. Also in the current corona times, this is a convenient situation because, of course, bladder cancer patients are usually elderly patients. Some are reluctant to come to the hospital because of the current corona crisis. You can see we had a larger problem in the Netherlands in spring. You see a lot of infections, but also a lot of patients being admitted and a lot of patients died. We currently have a new wave of positive testing, whether that's all infections, I don't know. Fortunately, there is not a new wave of hospital admissions and there's not a new wave of patients dying from the disease. But you can realize that in the spring of this year, patients were really reluctant to come to the hospital, and then testing from home really might be very convenient. Some practical issues are about this way I'm working. The advantages are clear. You have less workloads. My patients are happy. The test might very well be better than OI. We have to realize, like I told you, that our cystoscopy is for sure not optimal. And also you can monitor with this testing the upper urinary tract. And macroeconomically, if you would add everything together, this strategy is cheaper. Disadvantage, if you only look at the money for the hospital or the urologist, that might be a disadvantage because the hospital might lose some money because you don't have to do, you're not doing a cysto, and you of course have the costs of the Epigenetics test. And for me, the future would be bright if I could replace all cytology studies by a good marker. What about the patients? Well, we did a very nice study in 2000, and we interviewed 100 experienced patients, what they would do, because we were then very busy with all kinds of new markers, again, the BTA test and P22 test. And all patients said, well, we wouldn't mind to have a marker, but only if it is if it is very good and almost as good as cystoscopy. And we actually assumed at that time that cystoscopy had the sensitivity of around 100%. And we now know that that's not the case. Harry Herr in New York repeated our study and he found exactly the same. Patients really want to have certainty. They are afraid of missing cancer. So the bar is very high. And this is a recent study published again last year. And you see in the results of this study that most patients would like to have a biomarker which is 100% sensitive, and nearly 85% of patients still want to have at least 99% sensitivity. And the conclusion was that biomarkers should be as sensitive as cystoscopy. And again, then the assumption is that cystoscopy is 100% sensitive. And I think I hopefully convinced you, and of course you know that that is not the case. So one of my patients, who is a pathologist, by the way, was interviewed, and maybe I can show you his interview. It's 1.5 minutes, and I probably have to click on this twice. Again, I have to click on that twice. Ooh, that didn't work.
We can't see
Is it possible it is in another screen running?
You can't see it?
No, we can't see
No.
it. You need
Okay,
to share
I'll stop that.
your screen.
So apparently this didn't work, but you can find this on the internet. If you click on Epicheck and something like the Netherlands or something, you will find that. So ending my presentation after 35 minutes, and I'm happy that you are still around, is that the conclusions are that treat your patients according to the guideline, do good TOR, use instillation therapy, and make sure that your patients are diagnosed well. Follow up. Cystoscopies are inconvenient and part of a high workload and high costs. Markers to replace part of cystoscopies is an absolute unmet need. I really think this is something that we are waiting for and our patients are waiting for, but the bar is high. Epigenetics are promising, they are exploding, and certainly for non-muscle-invasive bladder cancer, I think methylation is one of the candidates to look at. Methylation is studied actually in all stages of bladder cancer, not only non-muscle-invasive bladder cancer. For follow-up, currently several markers have a very high negative predictive value, around 99% for non-low-grade recurrences. And again, we have to realize that probably with cystoscopy, we're not that good. And practical implementation is running, but I think it looks very convenient for all parties. And I think that was my last slide, so I'm happy to take questions if they're there.
May I be the first to ask?
Sure.
Okay, two questions. A, what are the stand of EAU, AUA, or the FDA about the Epicheck?
Oh, that's a very simple answer. I don't know. What I do know that the Epicheck test is being considered by the FDA. So what they're going to decide, to be honest, I don't know. What I do also know, we just had a meeting with some experts on Monday about the non-muscle-invasive bladder cancer guideline, which I'm not part of. But so we talked about that, and the non-muscle-invasive bladder cancer guideline group is reconsidering their advice not to use markers in follow-up, because they now realize that there are several markers that do meet the needs of urologists and do meet the needs of patients. So maybe not in 2021, but I'm quite sure that the recommendations about markers and follow-up will change very soon in the EAU guideline. For the AUA, I don't know. They update their guideline much less frequent than we do the EAU guideline. That's updated every year, as you know. But I'm quite sure that within 1 or 2 years, there will be a new recommendation on markers in the EAU guideline.
The other question.
I can't hear you.
Yeah, okay.
Sorry.
The other question, maybe I didn't follow up exactly what you said. On your daily practice, you use the Epicheck.
Yeah.
From time to time, do you stop and do cystoscopy, or you just continue with the EpiCheck unless it's a...
Now, what I currently do, you know, one of the reasons is I'm just been doing that since after the study, since around a year and a half. So just to get acquainted with the whole flow, the whole logistics. What I currently do is do cystoscopy. The next time I do the better EpiCheck. The next time I again do cystoscopy. So I alternate cystoscopy and the EpiCheck test. And, you know, looking at the enormous workload we have and the limitations we currently have due to the COVID crisis, I would really be very happy if I would have, in a larger number of patients, the possibility to do the test only. And of course, that depends on finance. That depends a little bit on what patients are accepting. For example, if they have to come anyway for a CT or upper urinary tract imaging, it's just as easy to do a cystoscopy. But, you know, and I'm probably not going to do this in all patients. But still, I hope that in the very near future, we can do more and more tests to reduce the workload and to reduce the complication of cystoscopy. It's not a very nice test, you know that.
Okay, thank you very much. Also, thank you for your wonderful lecture.
I have also two questions. The first question is, do you have specific data about the sensitivity of the bladder EpiCheck in the upper tract, specifically for upper tract or upper tract recurrences?
Well, I haven't really specifically looked at that. One of the groups in Italy has presented that last year at the AU at a symposium, and they actually find similar negative predictive values, because that's something that you're aiming at. You know as well as I that I get a lot of patients referred with abnormal cytology, TPS4, sometimes TPS5. We used to have carcinoma in situ of the bladder, and then they put into to urethral catheters. They probably take some urine from the bladder to the upper urinary tract, and then the upper urinary tract urine is also TPS3 or TPS4, but there's nothing on urethroendoscopy, there's nothing on imaging. So what to do with those patients? And the group from Italy found that also in those patients, the negative predictive value of the EpiCheck test for high-grade tumors is very, very high. The same ballpark as for bladder, so also above 90%.
Thank you. Now, the other question is about the combination of ultrasound in your practice. Would you trust bladder ultrasound as a combination with cystoscopy or perhaps with a urinary biomarker?
That's a great question. You know, I've been lecturing on bladder cancer in Europe and in America already for 20 years, and at every course I give, we ask the audience who does follow up with cystoscopy and who does follow up with ultrasound. My good friend John Palau from Barcelona always uses ultrasound, and it's always 50-50. You know, and I'm old-fashioned. I just want to see the tumor, so I do cystoscopy. And I totally realized that with ultrasound, you would absolutely also see a larger papillary tumor. What you will not see with ultrasound, of course, is carcinoma in situ. So if you then would combine that with a good urinary test, and to be honest, we didn't have a very good urinary test until quite recently, I wouldn't trust an ultrasound in a CIS patient. But, you know, I totally realized that if you do an ultrasound in a patient that had papillary tumors, and even if you miss a 5 millimeter recurrence, that's not very important. So that certainly is something you could do. But then, you know, I think if the test is well enough, you don't even need an ultrasound, just like you don't need a cystoscopy. But I realize that ultrasound is really something that you can use as follow-up. I don't, but I'd like to see the tumor.
Thank you. Do we have any more questions from the crowd?
Yeah, I would like to ask one question. Firstly, I want to say that it was a really great presentation. You mentioned that you are following small tumors when you are when the patient is under the low risk group. And do you think that if you see that the tumors are staying, you know, in the same size 3-4 times, you can follow them with the EpiCheck and to stop seeing the, to follow with the cystoscopy?
I certainly think. The funny thing is, for prostate cancer, we do a lot of active surveillance. For bladder cancer, for small kidney tumors, we do a lot of active surveillance. And for bladder cancer, it's still not really common practice, but there are more and more manuscripts, and I had to review the AOA of this year, so the virtual AOA. There were also a few abstracts on surveillance, active surveillance in bladder cancer, and it's really very effective. The risk that a patient, let's say, explodes during your follow-up is extremely small. So if I know my patients, and I know he had a small, low-grade thing, some time ago, I'm really very happy with active surveillance. Patients look together with me to their tumor, they see it on the television, I have a scope there, so I'm very, I don't want to damage the bladder as much as I used to do. So I'm very confident with follow-up. And to answer your question, yes, if I would have a patient with a small tumor, I would certainly, and I've done that, do the next time just a bladder EpiCheck to confirm that it is not high grade. That gives you more reassurance than what you see by your eye, because of course you can, let's say, estimate the stage and grade of a tumor quite reasonably if you're an experienced urologist. But if you have some help of a good marker, that also is very nice. So yes, if I have a patient of which I know that he has a recurrence, I wouldn't mind following him up with a bladder EpiCheck test. No problem.
I feel that we have a question from the chat below. Someone was asking about.
We have a question from where?
Someone just typed a question, from the audience.
Okay. Well, I don't see what has been typed, but maybe you can repeat that.
We can't hear you, Dr. Katz.
Sorry. The question was, do you use MRI sometimes for assessment of bladder tumors? Which is something that I believe most of us do not do.
Well, the funny thing is I get that question often, and the reason is, of course, that I was co-author on the VIRATS publication of Panabianco. To be honest, I never use MRI. But again, MRI, I have to be honest, and this was also again on the AOA this year, there were 2 or 3 abstracts on the value of MRI in the primary diagnosis of bladder cancer. It differentiates very well between muscle-invasive and non-muscle-invasive bladder cancer. So I think for follow-up, there's no place for MRI. But if you do a cystoscopy on the outpatients, you see a nasty-looking T1 or T2 tumor, probably the MRI could definitely help you to differentiate between a tumor infiltrating the muscle and not. So I'm quite sure that in the coming years, MRI will, in a certain group of patients, and of course not a large T4 tumor, and of course also not a small T8 tumor, but in T1, T2 tumors, I'm quite sure that MRI will have a place somewhere. But to be honest, currently, no, I don't use it in my clinical practice.
Great, thank you very much. Any more questions from the audience?
In the chat.
Question in the chat.
For some reason, I don't see the question in the chat.
No, I see it, but it was already, you asked already about the upper tract, and the MRI we just responded, so I don't see any other questions on the chat.
I think everybody is celebrating New Year, isn't it?
Exactly.
Celebrating at home, we're closing the country for 2 weeks now again. Starting from
for COVID. Okay.
Due to COVID, we have a very severe second wave now in Israel.
Infections are also hospital and IC and death, or what?
Hospitals and death.
Okay. So like I showed you, we have a new wave with regard to infections, and that's all, the younger people that are sort of tired about all the limitations. And as long as the older people are being careful, fortunately, it doesn't translate in a lot of sick people, and certainly not in an additional amount of death. So there is a wave now currently in the Netherlands, a real wave, like they don't care anymore. So they're not following the advice of the government. We'll see. There's a lot of economic damage. There's a lot of social damage. And there's a lot of damage in healthcare in my country, in my hospital. I saw a guy of 49 years old last Wednesday, so not yesterday, but the week before, with a bladder tumor of 11 times 4 centimeters. And he had been trying to make an appointment with a general practitioner for 6 months because he had hematuria. But he wasn't allowed to go there because of COVID and restrictions. And, you know, to be honest, I think 6 months ago, he was also metastasized, but still, you know, 49, and he'll die. So we will have some problems next year and after that with patients that have been missed this year.
I see one question on the chat. It says, are men more proactive for marker tests than women? I don't understand the question.
No, I don't think so. You know, I can convince both my female and male patients about a marker test. What maybe is the background of the question that, of course, the cystoscopy in males is a little bit less pleasant or more unpleasant than in females. But for the rest, I don't notice a large difference between male and female patients with regard to acceptance of, for example, in this case, the test or for active surveillance. As long as you explain well what you do, you show them what you do, you also explain potential limitations, I don't see many problems with compliance.
Okay. Ron?
Okay, if we have no further questions, we'll conclude the session, and we'd like to thank you, Professor Witjes. Thank you for the great lecture on behalf of the Israel Association of Urology, and thank you for being with us. And we hope to see you soon in one of our lectures again, or face-to-face, hopefully, when this COVID crisis will subside. And we'd like to say again, Shana Tova, which is Happy New Year, and Gmar Chatima Tova to everyone.